What a great pleasure to be here, and thank openEHR, fantastic organization. I must say this is a fairly new community to me, but I've got good friends, Monica and Luke here, and many friends from NHS England who we've worked in partnership with. But what's clear to me is that your foundational skills and talent is going to be absolutely essential if we're going to harness data-driven innovation for public good and for the benefit of patients. And I'm going to try and convince you of that. And I'm going to try and convince you that the intelligent design of 21st century health systems will require a convergence of care and research underpinned by standards. So that's, and I'll canter through this because we're a little bit late. So I'm going to talk about the pace of change, how we're trying to do this for the UK. And finally, talk about health data as critical national infrastructure for 68 million people. First of all, pace of change. I was 60 2 weeks ago. So in 1964, there were 3.2 billion people on the planet. About 18 months ago, the UN said there are 8 billion. It's quite an exponential rate of change. How are we going to deliver healthcare in an equitable way for 8 billion people? Big challenge for us in the UK is NHS productivity as well. And how do you improve productivity? You invest in people, you invest in infrastructure, and you automate. And data is really at the heart of this. In terms of the pace of change, the other thing we're seeing, this is a UK example, is inequalities, so-called coastal health. And if you look carefully, you'll see that those folk in the most deprived areas not only have reduced life expectancy, they have huge increase in years in poorer health. So how are we going to address that? And also I thought, because I was 62 weeks, I dug out an old picture. This is me on the ward, because I was a diabetes doctor in Glasgow in the 1980s. And I thought, what's changed in my medical lifetime? And sometimes we don't recognize the really exponential pace of change. So what have I seen? The Glasgow Coma Scale. I knew this. This was Jeanette and Teasdale, two neurosurgeons. This was data standards and data science. It was we still use it today, a predictive score of 4 responses used to predict patient outcome. MRI didn't come in until 1984. Statins, which most of us are on, 1986. Laparoscopic surgery came in 1990. I always say this is why you can never find a surgeon in a hospital. Smoking ban in the UK, 2007. Immunotherapy, CRISPR studies, gene editing, and of course, COVID vaccine. And what we're seeing is the same pace of change in technology and computational science. So in my world of diabetes, cardiology, renal medicine, we've seen huge progress. But if you look across computational specialties, sensor robotics, natural language processing, speech recognition, we're seeing a really rapid development in innovation towards ubiquitous networking, towards real-time speech recognition. But importantly, we see a confluence of these technologies. An example is by 2030, there'll be 30 billion devices globally connected to the Internet of Things, all producing data. And to illustrate that, this is a picture of one of our many recent prime ministers being shown around the national supercomputer. Exascale is 1 billion computations per second. It's unimaginable. And the other thing is scale. So this is the relationship between mortality and blood pressure in 5,000 people. That's the Framingham study. 50,000 people. And that's UK Biobank. So scale is going to be important. So at this point, we've got to collaborate at scale, arguably globally, if we're going to unravel common complex disease. And then we talked about AI in the panel earlier. So this is cribbed from Time magazine, and what it shows is these different types of AI, whether it's handwriting recognition, speech, image, comprehension. What we're seeing is not only surpassing human performance, but more recently, the exponential rate of improvements. But the feedstock of AI is data. And we shouldn't forget that. You will not have a glossy algorithm unless you've got good data. And indeed, ChatGPT has about 4.1 trillion parameters, and ChatGPT 4, which many of us have used, scrapes about 7 petabytes of data from the web to actually produce its algorithms. But what we're going to see, and this is why your world, or our world, is so important, is the need for human data. So this was in Nature about 3 months ago, and they talked about AI model collapse, because it's mathematical, but when you train and train and train on recursive data, synthetic data, you lose the tails of the distribution, and therefore you get model collapse. And the value of data collected about genuine human interactions with systems will be increasingly valuable. So this is why data as infrastructure will fuel the AI revolution. So it was quite a mathematical paper, but I loved the editorial in Nature which talked about machine learning, which showed if you recursively model on pedigreed dogs, after several generations, you have model collapse over here. That's what I used to look like on a Saturday night when I was a student. So what we're seeing in industry is a chase for data. So AI hit by copyright claims as companies approach the new data frontier. And we don't need much reminding of that. You know, not only the Nobel Prize in Physics, but the Nobel Prize in Chemistry was won for artificial intelligence. And this is coming to our world. And it's very relevant to the way we treat patients. So in the UK, we've got challenges with the NHS in terms of waiting lists, life expectancy falling, cancer survival being poor. But what we're seeing is, in terms of solutions, is data and digital being at the forefront of solutions. Now, we would not have had that 10 years ago. And indeed, Lord Darzi, this is an independent review, again pledges a digital NHS. So our time has come as a community, but we have to harness it, and we need to work in collaboration at scale. And what I want to talk about briefly is how we're trying to do that across the UK. So 7 years ago, our funders, including the MRC, NIHR, British Heart Foundation, CRQ, came together to say, can we unite the UK's health data to deliver studies on 67 million people to enable discovery, care, innovation, and trials? And this is a partnership endeavour. I see the row of colleagues from NHS England there, and we've had great fun over the years. Because our vision is to harness large-scale data to benefit every interaction for patients, trials, discovery, and public health. Data as infrastructure. So we are UK-wide. We sit in Wellcome in London, but we've got a UK-wide team of expertise looking at infrastructure, data, and services to configure this. And if you look carefully, you'll see Monica there. There she is. She doesn't come from Aberdeen. She comes from Leeds. So our vision, it's very simple. It's about exposure, well-defined with standards, outcome, well-defined with standards, and the ability to track journeys of care in real time on 67 million people. And we anticipate that the data ecosystem for health will change, because classically we've been a bit fragmented, a bit of a cottage industry with a one-to-one set of relationships. But as Heather has eloquently shown, if you coordinate through trustworthy systems, coordination and connectivity, you develop a data ecosystem that's trustworthy, a many-to-many relationship. So that's the thesis. How are we doing it? We've got a triple aim of infrastructure, data, and services, accelerate trustworthy data use. Secondly, rather than build it and they will come, nationwide demonstrator programs so that politicians, clinicians, patients see the value. If we wallow in the infrastructure or the standards without demonstrating impact, our pace will be attenuated. And lastly, this is team science at scale. How do we shape the future of health data research? So in terms of accelerated data use, one needs a data strategy. So we've got nationwide data, mostly OPCS 4, ICD-10, SMR in Scotland. We've got the world of electronic health records, which is where we're learning so much from your world. We're linking to non-health data sets. We're linking to what I call research-generated cohorts, stuff like UK Biobank, Our Future Health, clinical trials. Working with the Geospatial Commission, Met Office for environmental data, and increasingly looking at apps for wearables data. But to do this, you need a scalable, reliable, interoperable, sustainable, and secure infrastructure, data, and services. So we have a technology ecosystem, and Monica co-leads the data standards piece of that, the governance and trustworthy piece, the usable data, and then the training. And what we're trying to do is connect consumers to content providers through that infrastructure and software as a service. And to do that, we have nationwide demonstrator programs. So for example, we're looking at medicines for 67 million people because we spend £34 billion on it. We're looking at pandemics and outbreaks. We're looking at immunity inflammation. We're looking at cancer and cardiovascular disease on a UK-wide scale. So that's where we are. It's about delivering on the academic agenda, and this ecosystem has fueled 4,000 outputs with about 200,000 citations, and that shows the sort of connectivity across our ecosystem in terms of collaboration. But what we're now beginning to do is run studies at scale. So we've looked at 331 rare diseases in the entire population of England, 58 million people. We're linking to educational data, to looking at birth outcomes, how does it affect educational outcome in future life, and we're looking at personal monitoring data. And we've made this as open air as possible, so we have a gateway which anyone in the world can search the metadata of about 900 UK data sets. And it gives you discovery, it allows you to access data for requests, data discovery, plus in terms of trust and transparency, who's using data for what purposes. And there's this tools, open tools around the data to streamline the end-to-end user journey to search, discover, and access data so it's fair. And I won't go on to this, but Ed, you could log on to this now and have a wee look at the UK's shop window. So an example, a case study, COVID was mentioned this morning. So this has acted as an accelerator for data science. There was no health data news at 10 o'clock on the television every night than sports news, and that's atypical for the UK. But Patrick Vallance, who was our leader in terms of chief scientific advisor, said, let's do 5 things well across the pandemic: surveillance, long COVID, trials, transmission, immunity, and let's join it up in terms of our data infrastructure. We were asked to join it up. So this is a busy slide, but this is England, Scotland, Wales, Northern Ireland, so that's 68 million people. That was the data estate early on in the pandemic, and that's what it was like about 14 months later. And we can link at the individual patient level. And it's not just health data, it's social survey data, it's census data, it's intensive care data, it's testing, immunization data at scale. What that allowed us to do was to really answer questions important to policymakers globally. Here's Aziz, Edinburgh and Oxford. So within 6 weeks of launch of the BioNTech and AZ vaccines, we were able to look at our data to show that single-dose vaccination was 85% effective at reducing hospitalization. And that allowed us to move vaccine supply. You didn't need your 2 doses, so we basically doubled our vaccine supply and could move it out. Similarly, effectiveness, effects of variants. This was a study we did with Brazil, vaccine failure. So using COVID as a national case study during the pandemic. But what now we're doing is pivoting this to run studies truly at the 68 million level, working with NHS England, the Sale Data Bank, Northern Ireland and Scotland. And we link primary care hospital deaths, medications, COVID-19, climate pollution data. And this was in the Lancet in January of this year, showing that we could actually gear this up to run studies as a true nation. Now, having done it for COVID purposes, we're now pivoting it towards non-COVID related harm. And it's inclusive, 50 institutions, a level playing field, and a low barrier to entry. But I can't emphasize the importance of data standards here, because the amount of data scientists we have who are wrangling the data, trying to conform to a standard data model, whether it's OMOP or another model, is heroic. This is why your tools, your expertise, your talent is essential, because this should be real time for every learning health system internationally. And it's not just COVID, of course, domain-specific data sets. So this is something we're doing with Gates, LifeArc, ESI, looking at dementia. In the UK, there are 1 million people with dementia. There are 50 million people globally. New biomarkers for dementia. How can we use existing data sets so everyone doesn't need a PET-CT scan? There are now blood-based biomarkers, but increasingly there are digital biomarkers. So here's an example. We're using speech as a biomarker, 1 million eye images collected from high street optometrists, and a national imaging data set, exposure and outcome, to look at the predictive power of these tools. So we've put the entirety of the Scottish Imaging Archive onto a data set going back to 2008, 1.6 million brain images, and using that to predict future outcome. And to show this can work, this is Piers Keane from Moorfields. He was in Nature about a year ago now, because what we did was look at 1.4 million OCT images, that's optical coherence tomography, the back of the eye, and then he was able to predict Parkinson's disease 7 years before it actually developed clinically through a generative model. So this is the future, but data is infrastructure. Standards are essential. And just to finalize on the clinical trials piece, the ability to use data, which is well standardized, whether it's blood biomarkers, whether it's existing cohorts to actually enable clinical trials, is also a big piece where the standardization of data sets is going to be important. And finally, to say this is a global challenge. During the pandemic, we worked with the Gates Foundation to work across 60 countries to try and answer questions related to it. So I'll finish there. So the question I have for us as a community is, how do we sort the data? Because that's what we're trying to do, sort the data. But if we do it well, it's good for care, it's good for population stratification, public health. One can optimize trials, one can manage the health service to address the woeful productivity, and you can drive research. But this needs a new model of public-private partnership and collaboration, arguably on a scale never seen before. And it needs leaders at this interface of medicine, healthcare, computational science, standards, and social science. So thank you for your attention. This is a great community.
Thank you. Do you have time for a question?
Oh yeah, I've got loads of time.
Do you have
for
any questions? Okay, one question.
Hello, Severin Kohler from Charité. We work a lot with the biobanks, and my colleagues doing all the AI disease predictions. We work a lot with the biobank stuff. Yeah. And when I look what the guys are doing, and I'm not sure, what the data models you guys are using, really looking, under the hood. The problem I always see with the things we're doing, like we're doing it now, we leave out so tremendous amounts of stuff. It's really horrifying, I think. I mean, if you look at the biobank, usually when you look at a diagnose, right, you got like a date time and you got a terminology code and that's it, more or less, depending on what you're looking. And I think to cope with the way and the complexity future research is scaling currently, and the hypothesis is getting more and more complex, in the end you need a system that semantically can represent all that stuff.
Yeah.
And I think we have it, and it's called openEHR. I mean, that's what we found out in the last 5 years. Yeah, because we tried with AMAP, we tried stuff with FHIR, we did, just a lot of stuff.
Yeah.
And in the end, we just said, okay, in the end, what's interesting for us, it's stuff from the health record. So why we're not using a standard representing a health record, which is openEHR.
Yeah. So that wasn't a question, that was a very good statement. I agree.
One quick one.
Okay, yeah, one quick one.
Hi, I'm a clinician based in the NHS, and I'm an academic clinician, so I do a lot of research. For me to look at this is completely mind-boggling when you look at these numbers. When I started as a consultant, I was told we could not keep databases or even, Excel data sheets, and now we have this amazing amount of data. Now, my question is around the way the data are collecting with the NHS systems. I mean, if we could do one single thing, I always think that our priority should be to code, since at the moment coding is really patchy.
Yeah.
So I always get nervous when I see things around the biobank, UK bioresearch, which I utilize incidentally for research, because we tend to do double dipping a lot. So some patients will be signing up to bioresource, and the data will be collected on an EHR system, and they will be signing up to other clinical trials with the effect that, some of the data will be triplicated perhaps on these cohorts. I guess some of the error will be automatically corrected because you've got millions of people. But how can we improve the quality of the data we collect? And this goes to the data source in the UK. And can we start by a simple system, such as rolling out a national robust coding system, which will go from primary to tertiary care?
And insufficient time, money, and resource is spent at the front end of this. But if you have order-generating rules which mandate coding that is user-friendly at the point of care, then that is the only way that the quality curve will improve. Yeah, so it's highly variable. It's highly variable. But what we're also seeing is AI for data curation. And I think we're seeing lots of very interesting companies spring up which will help with actually improving quality through the use of AI and algorithms. But we've got to make life easier for all clinicians. And it's not, and insufficient. So.
Thank you.
Okay.
Okay.